Happy New Year and good afternoon, everyone. Welcome to the Center for Disaster Philanthropy's first webinar of the year, COVID-19, Year 4, Implications for Philanthropy. My name is Patty McIlreavy. I'm the President and CEO of the Center for Disaster Philanthropy. My pronouns are she, her, hers. I have more than 25 years of experience in international humanitarian policy and practice, bringing a unique blend of operational and strategic expertise to disaster philanthropy. Throughout my career, I have focused on improving the aid sector's effectiveness and impact, including philanthropy as a donor. I joined CDP in March 2020, just as COVID-19 was starting to impact the United States significantly. In fact, my first week, we held our first COVID-19 webinar. Some housekeeping before we get started. You can submit questions at any time using the Q&A box at the bottom of your screen, and we will answer them at the end of the panel presentation. If you're on Twitter, please use hashtag CDP4Recovery, that's CDP, the number 4 recovery, to share and join the discussion. And don't forget to follow us at Funds for Disaster. At the end of the webinar, there will be a short survey. Please complete this to help us improve our web offerings to better meet your needs. And finally, we are recording this webinar. It will be available on our website and YouTube channel shortly after the webinar is complete. Live captioning is available now via Zoom. Click on closed caption live transcript to access it. More accurate captions will be provided in the recording. This webinar is co-sponsored by Giving Compass, Grantmakers in Health, Peak Grant Making, and Philanthropy New York. We thank them all for their support. As we begin the webinar, CDP acknowledges that we are working from the stolen lands of the many original peoples. We recognize that Indigenous peoples have been displaced and disenfranchised from their land by socioeconomic and cultural disaster of colonialism, as well as disasters. We acknowledge when the U.S. was founded, there were exclusions and erasures of Indigenous knowledge about how to appropriately care for these lands, causing environmental degradation and destruction, which has had significant impact on disaster risk and communities. We are committed to dismantling the ongoing legacies, systems, and structures of settler colonialism and white supremacy. We commit ourselves to understand where and how wealth accumulation has harmed people, the earth itself, and the complexities of philanthropy as connected to that truth. Despite centuries of theft, violence, and murder, this is and always will be Indigenous land. Please join us and acknowledge the original peoples and their elders, past and present, as well as future generations. At the end of the webinar, funders will be aware of the philanthropic trends stemming from the COVID-19 pandemic, increase their knowledge of pandemic planning in a philanthropic context, and consider their plans moving into year 4 of the pandemic and the need to address root cause issues. Let's take a look at the results of the poll. So how would you describe your organization's ongoing COVID-19 response efforts? So it seems like it's in our DNA to some degree. It's part of our work, but not a major focus. Okay, but it's more people. There's still 38% are saying it's part of most things we do, and we're COVID all the time. So very much leaning towards that. It's surprising still for me to see year 4 that there are organizations who are not very involved in COVID. And I guess hopefully we'll hear about this in this webinar today, but you're probably doing more with COVID than you might think you are. Because there's so much in terms of ramifications and the ripple effects it's had for many of the communities you're working on, that even through supporting them in their recovery or community development, you probably are in some way increasing your work with the COVID. In terms of to what extent your organization has begun to prepare for the next pandemic, it's crossed our minds, but we're not worrying about it yet, and we'll do just what we did during COVID. Yeah, I mean, I think that's, I appreciate the honesty of that. That's often, unfortunately, what happens with a lot of this planning for pandemics, for big crises of this sort, and actually even for disasters and hazards we're aware that are coming. There's never enough money for mitigation and preparedness activities, and I think the answers there demonstrate that that's probably less to do with a lack of interest and more to do with a reality of the situation for so many of us. Now it's my honor to introduce our special guests. I'm looking forward to the information they will share with us today. Amy Liebman has devoted her career to improving the safety and health of disenfranchised populations through research, policy, advocacy, and education. She joined Migrant Clinicians Network in 1999 and currently serves as the Chief Program Officer, Workers, Environment, and Climate. Amy has been a strong advocate for worker health and safety during the COVID-19 pandemic, pursuing regulatory protections for workers and leading programs to improve access to care and education for migrants and immigrants. Welcome, Amy. Allison Neiman is the Executive Director of Mindful Philanthropy, an organization that acts as a catalyst and multiplier for investment in mental health, addiction, and well-being. Allison brings 20 years of cross-cultural and executive leadership expertise to catalyze impactful funding in mental health, addiction, and well-being. Through various national and executive roles, Allison has scaled and restructured entrepreneurial initiatives and expanded new efforts with a global nonprofit, including 8 years in Russia. Welcome, Allison. And Julian Shope, a former colleague of mine, is the Vice President, Humanitarian Policy and Practice and Interaction. Julian represents interaction in different global forums of the humanitarian system and its governance. Before joining Interaction, Julian worked as a senior policy officer for the International Council of Voluntary Agencies, focusing on forced displacement issues, and has also spent a large number of years in operational positions internationally. Julian is a member of CDP's Advisory Council. Welcome, Julian, and welcome to each of you, and thank you for taking the time to share your expertise with us today. The first cases of a new and unusual sickness were reported in late 2019, and by early 2020, we had a new type of coronavirus, commonly called COVID-19. Now, as we enter year 4 of coping with the pandemic, we see new variants sweeping the world, and despite vaccines, people continue to get sick, and in some cases die from the virus. As we hold our discussion today, I want to start by looking back before moving into needs and gaps, and then the next steps. Amy, let's start with you. Can you paint a picture of the issues faced by migrants and clinicians at the beginning of the pandemic back in 2020?
Sure, and hello, everyone. So Migrant Clinicians Network is a national nonprofit dedicated to health justice, and we have 2 primary audiences: our frontline clinicians caring for migrants and immigrants, and we have our immigrant and migrant communities. And so when we take a look back, and I don't want to traumatize anyone, but when we look back at the beginning of the pandemic, it was a story not only of sickness and death, but one of moral injury and failure and neglect of government. The pandemic began rather indiscriminately. It affected all types, regardless of race and ethnicity and wealth. And then that quickly changed as our policies took hold. Schools and workplaces closed or went online. And then those that were deemed essential had very few options. And those on the front lines of our healthcare system and our food production were expected to work. And in many cases, the workers had no other economic option to survive but to go to work. For our healthcare providers, they were expected to care for the ill with limited PPE and few policies that protected them, such as basic airborne pathogen standards. For a good deal of the pandemic, our healthcare workers were 3 times more likely to be infected with COVID-19 compared to the general public. Next slide, please. For our immigrant and migrant and BIPOC communities, the health inequalities were staggering. For a large chunk of the pandemic, the case and death rates in our Latino and Black communities were more than 2 to 3 times that of our white communities. And that was largely due to the work that they were doing. About 70% of our immigrant workforce are considered essential workers. And for those of us who live in communities where immigrants are part of our food production, the impact of COVID was simply striking. I live in Salisbury, Maryland on the Eastern Shore, and within a 75-mile radius of my home, there are about 10 chicken processing plants. Haitian, Guatemalan, Mexican immigrants, along with members of our Black community, work in these plants, and they were just largely unprotected. There were a few sick leave policies, limited PPE, poorly ventilated workplaces, and they quickly became sick, and many died. And then their children and family members started getting sick. And then that's when the blame started, right? Oh, it was their culture or the way that they lived or in their close quarters. And there was very little acknowledgement of the workplace conditions that were conducive to spreading COVID. The blame was easy, and it's coincided with chaos and an inept federal response, lack of information, and incorrect science. And I remember so clearly, I was in our Puerto Rico office waiting for my family to come down for spring break, but I decided to come home on March 13th. And I saw two women in the airport wearing masks. And I thought to myself, why are they wearing masks? The CDC says this is not an airborne disease. And so I got on the plane, disinfected my seat, and went home to my family.
Allison, a similar question. What were the first needs that began emerging in the area of mental health and emotional well-being?
Well, thank you, Patty, and thank you to the Center for Disaster Philanthropy for having me today. And before I jump into that, I feel like we have to back up and talk about what was happening with mental health before the pandemic. So we know that mental health and addiction disorders were already of concern in the United States. In fact, in 2019, roughly about 21% of adults in the US had a mental illness, and loneliness was already on the rise. But we do know that the pandemic really exacerbated and accelerated a lot of the existing problems. As a society, we underwent a collective trauma. There weren't places to gather outside of our homes, such as libraries or places of worship, workplaces. I mean, I was in a New York City apartment with two teenagers who were doing school on a screen, and that physical isolation required to really stem the spread of the virus resulted in much more social isolation. People lost friends, and loved ones also faced grief. And so losing jobs and other forms of economic hardship caused an increased stress. And we know that with every increased percent of unemployment, suicide risk and mental health challenges increase as well. And as mentioned, while everyone was affected, there are certainly different populations that have different mental health needs. Frontline workers faced increased dangers and stresses every day. Many office workers shifted remote work, and students had to cope with not seeing friends, missing out on milestones like graduation, prom, and summer camp. And parents and caregivers faced added burdens of having children at home. So this coinciding social unrest and protests also affected people of color differently. All of these factors globally combined to see a 25% increase in anxiety and depression in the first year of the pandemic, with here in the United States, roughly 1 in 3 of US adults reporting stress, anxiety, and a great sadness that was difficult to cope with. And yet only 1 in 3 were actually able to get help from a professional to deal with the feelings. We also saw that substance use and overdoses increased during this time. In the early months of the pandemic, about 13% of Americans reported starting or increasing substance use as a way of coping with the stress and emotions related to the pandemic, and overdoses unfortunately increased by 18% nationwide compared with those same months in 2019. And then I want to highlight that our nation's youth were really particularly vulnerable to the mental health effects of COVID-19 early on. Prior to the pandemic, about 1 in 5 school-aged youth already had a mental health diagnosis. And since the start of the pandemic, students have really increased in mental health challenges such as social withdrawal, self-isolation, anxiety, and depression. And in the last year, 44% of youth have reported feeling sad or hopeless. And these have worsened the existing disparities in youth, with those reporting depression, substance abuse, and suicidal thoughts. So and then we of course have to mention the learning loss that's creating stress as well, leaving students about 5 months behind in math and 4 months behind in reading. So those are just the early effects of the pandemic. And we know that we continue to see the effects of the pandemic as it relates to mental health and well-being.
Thank you. I mean, Amy and Allison, what I really, it's kind of interesting to me. It's 3 years ago, isn't that long, but it's amazing how much we've forgotten about those early days. So it's really valuable to have that reminder, like when did you start seeing the masks? When the whole shaking the hands, the ABCs, all the things that occurred, adapting, because now, again, it's not that long ago really, but it feels a very long time ago. It's been a long 3 years. So it's really important to have those reminders. Julian, Interaction members, they work around the globe. What challenges arose with the organizations that were first looking at how to continue to give the assistance overseas? when the COVID-19 virus first broke out?
Thanks, Patty. The initial challenges were really practical and had to do mostly with duty of care. There was no option for our members responding to disasters or to displacement, to refugee situations, just to completely stop working. There was no remote work option. So how could we protect our staff that were to continue services to the people that we serve in the field? And this is where it's very comparable, I think, to what Amy was articulating initially around the lack of PPP. And globally, it was even exacerbated by the fact that the U.S. government had an edict, so to speak, or a directive that U.S. international organizations could not, with U.S. funding, buy PPE for their globally, to work globally. It was only eligible to be purchased domestically. So that was a big issue that we worked with our members on, and with strong advocacy, we managed after 2 or 3 months to reverse this rule, but it created a lot of problems in terms of making sure that we could protect our staff so that they could continue to work. And I think that's an illustration, I think, of the reaction globally from countries, which was, okay, let's now become more isolationist. Let's try to protect ourselves, and let's not really care about others, which is not very effective, I think, from a public health perspective, as I think my co-panelist would confirm. And on top of that, created a lot of risks for objectives that NGOs and the international communities had globally. And we saw that replicated after that when the first vaccines came online. And again, rich countries tended to hoard those vaccines at the expense of less fortunate countries that could not afford them. And it took a little while to get COVAX started, which was this facility to provide vaccines to low-income countries. A final challenge, I think, that arose also to respond to other types of crises that existed through the first era of the COVID period was the impossibility to travel, of course. So if there was a need to surge from a humanitarian perspective in a specific context, for instance, when the civil war in Ethiopia broke out 2 years ago, the COVID restrictions were such that sending surge capacity to respond to the crisis in Ethiopia was almost impossible, as the quarantine time that was requested when you arrived in Addis Ababa would take you 10 days. You had 5 days to actually implement programs, and then your visa was done. So you had to go, and that was the case in many instances. This could have been seen as an opportunity for our community to work more locally, and I think a lot of our members use this strategically to better engage with local partners, and that's maybe a positive outcome of these travel restrictions. But I'll leave it at that for now, Patty.
So Julian, that was so interesting. I'm going to stay with you and look at, as we move into year 4 of the pandemic, what are the issues, the trends, the gaps that you're seeing from an international perspective? Which of those issues remain, and which are moving in which direction?
Well, I think for our members that work in health now, COVID-19 in all the responses that we do is now, one more disease added to the list. There is nothing really exceptional about COVID response right now when you look, for instance, at our members' work in Africa or in Afghanistan or in Yemen, in the sense that it is a primary health care concern like others. Sometimes from a US-centric perspective, we see COVID's mortality as extremely high, which it is in this context. But of course, for a number of our members and the people we serve, the main killers are still malaria, are still measles, are still cholera, and COVID barely registers to some extent in terms of mortality. So again, it is very much a concern for our staff and to minimize transmission, like with many other diseases. I think one unintended consequences and trend from the COVID response, and linked a little bit to what I was just saying, is that the international community focused all its efforts, understandably so, on COVID response and on vaccine production, on vaccine distribution. At the same time, we kind of lost focus on other priorities in terms of international public health concerns. And what we've seen, unfortunately, in the past years, or the past year, with the data that we have, is we have the largest decline in childhood vaccinations in 3 decades. There's more vaccine hesitancy globally, more and more measles outbreaks, as I was saying, which are extremely deadly for children. And the pandemic has strained health systems, as Amy was alluding to, also in this country. And malaria also is heavily on the rise. So while we were successful in large ways, but in curbing COVID, other international priorities in terms of public health, unfortunately, have not done so well.
That's such a sorry, go ahead.
Another concern, I think, linked with funding now, is between COVID, climate impacts with droughts, as well as Ukraine. What we've seen is that, and it's positive, the international community and the global governance of the humanitarian system, as well as governments, has really stepped up. I mean, funding was available and is available for all these responses. I, however, think that now we are seeing the end of this, and I am a little bit worried now that funding to deal with longer term issues that we've been trying to solve for many years will not be readily available in the coming years.
Great, thank you, Julian. And such a critical point for, I think, the donors on this call to really hear is, great, we appreciate the generosity that went into COVID, but we need you also to lean into these other areas, as Allison spoke about the learning loss, as Amy spoke about the sectors, the economic sector and the health sectors under strain, as Julian mentioned, all these other areas where sustainable development goals and humanitarian needs are just we're losing ground. And we really need to lean into this in the same way we leaned into helping bring COVID under control, because we've proven we can do it if we want, if we have the energy behind it. Allison, I want to come back to you. In the planning call, you mentioned that loneliness and exhaustion are the 2 top emotions people are feeling right now. Can you tell me more about how that plays out and how funders can support that the response to these things?
Yeah, sure thing, Patty. And I want to say this data comes from the How We Feel app that's out there. It was developed by Dr. Mark Brackett at the Yale Center for Emotional Intelligence and launched by Pinterest most recently over in the last year. And the app asks users to complete just daily 30-second health check-ins, and it gives them tools to help manage their feelings and emotions. And so recent user data shows that loneliness and exhaustion are, in fact, kind of the top 2 emotions people are facing. And we talked earlier about the acute mental health needs that were faced in COVID, but what we're seeing now is more long-term needs in our population, and they're lingering and even continuing to grow. So as I mentioned, loneliness has been a serious and growing problem even before the pandemic, but it's increased. And about 36% of all Americans and 61% of young adults feel serious loneliness. And this is really important because it contributes to overall health decline and risk for other things, such as dementia, obesity, depression, high blood pressure, and heart disease. And I'm sure we've all read the articles around what's happening in the workplace. There's exhaustion and burnout, both at home and at work. And we know that nearly 3 in 5 employees reported negative impacts of work-related stress, including lack of interest, motivation. And we see that, as mentioned earlier, healthcare workers are particularly vulnerable to burnout, and teachers, where there's a lack of teachers right now in the public education system. And so I want to, talk about also the public healthcare workers. About 50% of them were reporting symptoms of at least one mental health condition, like anxiety and depression, and increased levels of PTSD. And then we also see informal and paid caregivers, who are usually women, are at higher risk of stress and burnout. And so as we think about what funders can do, if we can go to the next slide, they can help by really integrating mental health into what you're already funding. So you don't necessarily have to think about supporting things outside of your issue areas and the things that you focus on, but what is it that you can do to insert mental health into the programs you already have? So for example, we know that social connectedness and strong relationships are one of the biggest protective factors associated with mental health prevention. So supporting those structures and places where people find community, both informal and formal, to enable them to provide their core services and supports that bring people together, and then measure their impact on mental health and well-being. So examples of this include groups based on religion, cultural or ethnic identity, tradition, after-school programs, athletics, access to other extracurricular activities and community groups where that sense of community and identity can really be experienced. And then, really support the integration of mental health into these places. So really supporting training to educate and increase awareness, tools for screening for mental health issues, and early intervention and access or connections to treatment and support for the appropriate level of need. And then integrating mental health into the organizational level. So things such as workplace level and workplace capacity, staff levels such as skills and resources, and the service population level such as training and access to supports. So if you think about some of those youth serving programs like after school activities that build positive relationships, some of those might be the YMCAs, Boys and Girls Clubs, Big Brothers and Sisters, Native American Welcoming Center. They all have strong and protective effects at helping to form that sense of community and preventing loneliness. We actually have a guide that's coming out in the next few weeks around highlighting how people can support culturally led programs, in particular, strengthening communities of color and building resilience. And so these culturally led programs really do help promote those traditional healing practices and give a deep understanding of factors such as racism and intergenerational trauma that can lead to those feelings of isolation and loneliness.
Thanks, Alison. I mean, we're definitely hearing some of the ramifications of this through the nurses' strike, for example, going on right now in New York.
Absolutely. Right? Yeah, that big 2-page spread that was in the New York Times this week.
And I see similar with my son, for example, just that going back to being out and playing and being out. 3 years is a long time of a 16-year-old's life, right? I mean, it's definitely an adaptation, and I'm glad to see that your program is really helping guide people on how to help better and help these children move forward. Amy, I have a couple more questions for you. First, one of the areas the Migrant Clinicians Network spent a large amount of energy on during the height of the pandemic was in provision of technical assistance. What types of things did you do, and how can funders do more technical assistance themselves?
Great. So we're mission driven, and without any funding or staffing, we sprinted into this pandemic, and we had no idea that we were entering a marathon. So we, through all kinds of virtual venues, we translated that rapidly changing science, those rapidly changing guidelines. We brought panels of clinicians together to talk about what they were doing with their patients and how they were keeping themselves safe. We did a lot of advocacy for policy change to make sure our clinicians were being protected on the job, and also workers were getting the protection that they needed. I think the biggest thing that we did in those first months of the pandemic is that we listened. We heard the needs, we heard the challenges, and we kept responding. We also we're quickly learning that this was not just a pandemic of COVID-19, but of misinformation, disinformation. And by May, we were presenting to hundreds of clinicians one of the first national webinars on the airborne aspect of COVID-19, which was so critical in how we were responding. Like Julian said, we faced some challenges from our federal funders. We stood up when the government told us to stand down, one of our federal funders said, you cannot use your federal funding to train workers on how to stay safe from COVID-19. And so we took a deep breath, we did our deliverables, and we doubled down and then provided the education and training that our workers and community health workers needed. We also, in response to what that Allison was talking about, we provided psychosocial support for our frontline clinicians who were really suffering from moral injury and the trauma that they were witnessing. By fall of 2020, the funding situation changed and we were able to pivot and hire some staff. We were partnering with community groups all across the country and developing culturally contextual resources that they could then, put in photos of trusted messengers and their logos and local phone numbers and really easily adapt, but had all the right content and the science that was needed. This work evolved into our Vaccination Is campaign with over 300 resources in Haitian Creole and Spanish, Spanish and English. And it's been very, very successful and well used. We did an extraordinary amount of work of pulling together local health departments to have a bi-directional, equal relationship with the disenfranchised communities that they were serving. They had lots of challenges with the equity aspect and trying to reach communities where they were at. One of our most intensive partnerships involved a network of more than 20 organizations around the country. Our partner got an $8.5 million grant that they were expected to spend in 6 months to do vaccine outreach. And so gearing up for that and getting it out the door was incredible. We did a ton of technical assistance, looking at learning collaboratives, sharing challenges, sharing clinical content, guideline updates, because they were constantly changing. And then we were also dealing with racism. One of our community partners brought to our learning collaborative that they were trying to do a vaccine clinic in a largely Black rural community, and trucks waving Confederate flags surrounded them. So how are they able to get these messages out to their members? But I am happy to report that a lot of the investment in community groups in MCN and many other organizations, we saw some great successes and we saw some changes in that disparity lens, where we actually saw some communities where Latino vaccination uptake was greater than some of the white communities. So I'll leave it at that.
No, thanks for that, Amy. I want to have a follow-up on that, which is, there's obviously a need for funders to continue to support networks while also recognizing these hyper-local needs that you've identified. How do you suggest funders support and balance the two areas of need?
Right. So that hyper-local aspect is super important, and it was critical in the public health response. And so really looking at some of the models where that worked, the role of the community health worker was essential, I think, throughout the world and in the United States. And so continuing to nurture organizations that are supporting community health workers outside of a crisis, but allowing them to focus on health equity and justice and keeping that support going. One of the things that we did, and that I think is needed with some of our hyper-local groups, so we provided, as a national organization, a lot of financial technical assistance, like $8.5 million for an organization that doesn't have that kind of a budget, and helping them get that money out the door and staff hired took a lot of work. But it was exciting to see that they could do it, with a little bit of support, they could do it. And the work that they did was amazing. But what happens at the end of that 8.5 million 6-month grant? There was a lot of layoffs. We lost a lot of that institutional knowledge that we had built. And again, we went backwards in that work that we were doing to address health disparities. We were moving that needle, and then we're going backwards. So I think sort of finding that balance of supporting these local groups, but making sure they're also getting the support on the technical assistance. We can't expect them to be public health experts, to know all the content, and we can't expect them to get credentialized. We have to use their models, but be able to provide them with the information that they need. The other thing that I think is going to be really critical moving forward, and we think about our funding, is recognizing the brokenness of our public health system and the blows that it took, as well as our general health system. And so if we're going to advance health equity and advance health justice, looking at some of those areas that we need to focus on. I've talked a lot about that moral injury, and Allison mentioned some of the mental health work that needs to get done, the investment in building trust again. I mean, I talked even about my own experience. I still get mad thinking about, I didn't have that information as I went from a city that has cruise ships docking into it to get on a plane and get home with my family and potentially expose them. And we need to be investing in policies. You know, we look at so much of our policies in the United States, we're looking at, you know, these individual workplace policies, but paid sick leave is public health policy. You know, all of these worker protections are not for the benefit of the worker per se, although they do benefit them, and that's our focus, but they're public health policies. And so those are some of the areas that we need to focus on. And lastly, again, our broken healthcare system. I think we made enormous advances with the universal access to vaccines. And what could we do to advance health equity and health justice with the universal healthcare access? I know it's an old topic, but if we're going to address pandemics in the future, looking at these aspects are really, really critical.
No, thank you for that. And I'm sure it resonates very well, you know, Allison, with yourself, and Julian, with you, with your own spheres in terms of the international and the mental health is just those issues of collaboration. It takes us all, you know, really building trust as we come out of this pandemic. Allison and Julian, I'm going to ask each of you one more question, and I have a group question for each of you. So Allison, we're in a new reality as we move forward. COVID isn't over, and as this year's flu and RSV seasons have shown, the risk of pandemic is ever present. What could funders do better to support the mental health impacts from COVID and prepare for future shocks?
Yeah, thanks, Patty. There are a couple of things that we are really focused on and major issues that we're facing in the mental health sector. First is really the lack of mental health workforce. So currently in the United States, there's about an estimated 350 individuals for every one mental health provider, but we think that these figures may be actually an overestimate of the mental health professionals. It may include providers who are no longer practicing or accepting new patients. And then we know just from our last question that healthcare providers are burning out and resigning at alarming rates, including mental health care providers. And the Surgeon General is predicting a national shortage of about 3 million low-wage workers in the next 5 years and about 140,000 physicians by 2033. So we really think that funders can invest in solutions that address the clinician burnout, providing more clinicians and getting them into the pipeline. And this includes, you know, paying higher wages, creating a sustainable place where they can show up to work, whether it's some of the policies that were just mentioned by Amy. Second, we know that there's never going to be enough, clinicians to service the need, especially if it's short-term needs. And so really focusing on the paraprofessional and the peer workforce that's out there and that can be a solution. So peers, community healthcare workers are a vital part of the community, of the mental health workforce, and training community members such as barbers, coaches, religious leaders, and pediatricians can help them all be bridges to mental health services as they come in for a primary care visit, or as they're getting their hair cut, or they're visiting a house of worship. And then, what was already mentioned by Amy. So really thinking about the systems and structures that are out there, such as disability leave, paid parental leave, flexible work policies, they all help people deal with the health challenges that are out there and the mental health challenges. And a lack of these policies and structures in place really affects shift workers and low-wage workers, which only continues to widen the disparities between income classes. And so circling back to something Amy said, a lever that funders can pull on is policy. So by funding advocacy efforts, it can really build those proof points for government to scale. And this includes, especially as it relates to mental health parity. So mental health services can often be covered less, are reimbursed at a much lower rate than other services because of the stigma around mental health in our country that's persisted for decades. and they can support policies that are more specific to topics like mental health in schools. Last year, we released a guidance called Thriving in Schools for specifically education funders, but really all funders, to learn how they can integrate different programs, policies, and supports into their education portfolio and really support the young population that we talked about that's been really hit so hard by COVID-19 and that are experiencing significant mental health challenges right now. And then I really want to close with this final point, which I think is the most important, is that we really have to start thinking about mental health holistically. So mental health is a part of every system, and we can integrate it into the things we're currently funding, such as homelessness, climate, education as mentioned, and more. And so we at Mindful Philanthropy, we don't see mental health just as its own issue. We see it as an essential and integral part of helping everyone thrive. So weaving them into the things that you're already funding, such as the things mentioned above, community spaces and schools, to meet people where they're at, including the most vulnerable members of our society.
That's great, Allison. I really hope that's one of the things that comes out of this pandemic in a positive way, is kind of breaking through, the stigma of mental health and recognizing it's integral to so much of all that we do in terms of a healthy well-being. Julian, similar question for you. How do funders, support organizations, whether US based or international, to continue their ongoing humanitarian work while also working within this context of COVID and also preparing for new crises that may come? How are they managing all of this?
Well, I think what we're looking at is, and I think the parallels with the domestic realm are quite striking, is being more local, working more locally, strengthening the local partnerships, and that would be, a plea for funders and individual donors, is to really choose international organizations and that really work very closely and that have a track record with local partners, because what COVID has demonstrated is that we can be cut from anywhere at any time, and we need to really invest more and more in local capacity to respond with limited support. And that goes also in terms of supplies. What COVID has revealed with all the PPE issues that we've briefly alluded to before is we need to have supplies pre-positioned in different areas internationally if we want to be effective in the responses. The tight supply chain system of globalization has shown its limits with COVID, and we need to rethink this also from a humanitarian response perspective as we look at this going forward. The final point that I'd like to mention, which is maybe less evident, has to do with information and disinformation. What we saw is we've invested collectively as an international community a lot in, vaccine development, logistics to get vaccines, to get PPE to places once everything was back online. And what we've discovered, and we've discovered it also domestically, is we worked on the supply side, but not really hard enough on the demand side. So what happened in a country like the Democratic Republic of Congo is shipments of vaccines were brought to Kinshasa, and then when international organizations started working with the Ministry of Health, they discovered that there was no demand from the population for a number of reasons, and that already a certain amount of disinformation was circulating about what was in the vaccines, et cetera. And so I do think that going forward with the multiplication of disinformation and this parallel digital information spheres and ecosystems that we see, we need to also be thinking about response and public health in digital terms. How do we better inform? How do we ensure that people have the right tools to make their own decisions? And I think that's an area that's underinvested in. I think from a funding perspective, how do we fight against disinformation, not in the political realm, but in the public health and response realm? So I think that's one thing I think that going forward, we have to think about more collectively. Finally, I mean, as I mentioned before, for donors and funders, please try to look beyond the headlines. I do think that COVID response, as well as, again, I'll mention Ukraine, tend to take all the attention, and sometimes it is at the expense of other needs that are as important, and that we need to be cognizant of. On your question, Patty, regarding are we ready for the next big one? I don't know. I think we've learned a lot of things, but as you were alluding to at the intro to this panel, I think everyone tends to be going back to business as normal, unfortunately. And if we have, God forbid, an airborne Ebola, we will be struggling to respond effectively.
Thank you, Julian. We're going to move to question and answer in a minute. So please add your questions to the Q&A box at the bottom of the screen. And while you're doing that, question for everyone to answer. For all that the pandemic has taken a toll on everyone, those on the front lines of physical and mental health service delivery definitely felt the impact the strongest. At one point, they were lauded as heroes. There was every form of recognition that could be imaginable. That's faded away. What's happening now? And just in briefly, in one line, how can funders reinforce the broader health infrastructure, just building on what you've already highlighted? Allison, why don't I start with you?
Yeah, sure. So I've already mentioned two in terms of investing in the mental health workforce, and then really being able to expand the workforce by equipping community members. The other thing I'll add is really around telehealth that's helping expand access to services. So it accounted for less than 1% before the pandemic, and then 13% during the pandemic, and has since stabilized to 8%. But it remains a strong, mental health and substance use treatment. And so that's a place where we can really think about and focus.
Amy, why don't you go ahead?
So I think, we've touched on a lot of these areas, but that investment in our health infrastructure and that the workforce that fuels that infrastructure is critically important as we move forward. I think the looking at the community health workers and that model, I've worked on that model for years and years in different countries and in the US, and it is very effective. But they needs to include nurturing, support, and funding so that they can do their job and not expecting it to be a volunteer place. And then I think Allison touched on so many things that are so near and dear to the clinicians that we serve, and it's a struggle. I mean, they've taken a hit because of the misinformation, disinformation, and trying to get folks to respond. We have cases of measles increasing in the US. And so the energy that it has taken from them and repairing that and looking at workplace policies and nurturing our clinicians so that they have the strength and the energy to move forward and keep at the job that they do so well.
Julianne?
Yeah, I know we're over time, so I'll just underscore what Amy just said. I think community health workers in all locations, if you're looking at a piece of the infrastructure from that's the most bang for your buck, invest in community health workers internationally.
Great. So now it's one of the questions we have is seeking advice. How can organizations discuss their ongoing needs related to COVID-19 in response to recovery when they're applying for funding? What might be some ways that they could be working with their funders to address and bring that into their proposals? Allison, do you want to go ahead with that?
Sure. I mean, I think similar to what we've talked about, there's acute needs and then there's the lingering needs, especially with mental health. So working those into the different proposals, because those are some of the lingering needs. And we're hearing from more and more funders that even programs that they funded before the pandemic are coming to us and saying how we have to service and provide services of mental health to the different constituents and the communities that we're serving, and how can we help them integrate this into their programs and thus get more funding to service the community. So that would be just one thing I would add, is learning how to incorporate that into the funding proposals.
Anyone want to add into that? guidance for funders, for grantee partners?
One thing that I'll just throw out, I'm from a little bit of a different perspective as I receive funding, but we have this joke at MCN, like we have these ugly babies, like we love them, our constituents love them, and we can't get them funded. And one of our areas is providing that psychosocial support for clinicians on the front lines, and we don't really understand that disconnect between that need for psychosocial support, helping them address the systematic, challenges that they're facing, and working with workplaces to allow that support to take place. And so it's a question that we struggle with, and we have, and I think it's a core piece. And I love what you said, Allison, about integrating that into not siloing it. And it does really need to be integrated. And we're looking at that from all different kinds of views. So instead of like asking funders for like, hey, could you focus on our mental health programs, or like looking at like a broader clinician support program, looking at a broader program of training workers and addressing some of their psychosocial needs rather than doing it. And we've been a little bit more successful from that perspective, as opposed to saying, we really need your help focusing on mental health. So some of that would be great for other people to see our beautiful babies and not see them as ugly babies.
I think none of us ever believe the babies are ugly, right? I mean, that's part of the myth there. So Julian, from the international side with the Interaction members, are you hearing anything about how they're adapting, they're changing? Are their asks of donors different? I know the donors are slightly different for some of them, but are they asking in a different way or asking for different conditions?
I think there's been a recognition in the international realm also about the importance of mental health and a much bigger realization of for lack of a better term, duty of care to staff, national and international. I think the traditional view of humanitarians is kind of a cowboyish perspective, and we've moved, thankfully, very, very far away from that. And so I do think that now part of our members' policies really do include all these considerations, and there is much more support that is provided to staff on a continuing basis, as well as it relates to trauma linked to responses. And I think that's also recognized at least by institutional donors, and that is part to some extent of it is becoming part of the cost of doing business. I think a little bit like security used to be 20 years ago when aid workers started to be targeted, and then suddenly, maintaining aid worker security was accepted as a cost of doing business. Now I think there's a more focused perspective on aid workers' mental health and the like.
So we've been talking quite a bit about the type of funding and how we seek the funding. I'm also curious about some of the programming changes we've made. So there's been an increase in cash programming, for example, emergency cash assistance, mutual aid, those types of things that have kind of helped communities advance and develop. How do you see some of that transitioning in well, I don't want to say post-COVID world, because it probably won't be post, but in our new world that we have now? Amy, do you want to start?
Sure. We're involved with a couple programs in the U.S. for food and farm workers, and I think they're incredibly important when we have the data that they work, and it's making a difference in terms of people's lives. And then on a sort of a little bit more systemic level, I'm just going to give a shout out for philanthropic trust and the kind of funding that will look at the community groups that are doing the work for health justice or the work for public health, and recognizing that they're doing some good work and supporting some of their general operating costs, rather than forcing them to constantly be innovative outside the box with new programs, when some of their constant stuff works really, really well.
Did anyone else want to come in on that?
I'll just say, Patty, that what we're seeing, and this might be assumed, but we're seeing a bigger shift toward just the operational grants and encouraging funders to really give operational grants, because at the local level, at the community level, these organizations know how to best support, their communities and constituents, but also what they might need to support their own thriving within the organization and to make sure that they're in a place where they're sustainable and can really grow. So a considerable shift toward that, even though it started before the pandemic.
And Allison, I love that point. I want to kind of pull that, and because we're talking about, we gave advice to grantee partners. And what is the advice we want to give to funders? How do they prepare for the next pandemic? How do they be the best donors that they can be to, set up for success, those organizations working with these communities? Allison, why don't I start with you, since you kind of got us off on that?
Yeah, I mean, I think just what I just said, but I think also being willing to jump in, and I'm coming from the perspective of mental health. What we see right now are funders that can be often very hesitant to fund mental health initiatives. Where do I start? It's overwhelming. Where's the evidence? How do I evaluate? But we just encourage funders to dive in and get started and learn as you go, and to try to make the best decisions. But you're never going to really know until you get in there and start trying things, rather than, starting these multi-year kind of learning journeys. But, of course, in a pandemic, you really have to just not be risk adverse. So take those risks and be willing to learn and be humble and ask the questions of those on the ground. Great.
Amy, and then we'll go Julian.
Yeah, I think, Allison, you're summing things up so nicely today. But I one of the things when I look back, particularly at those first 6 months, some of our funders outside of the federal government, but some of our funders just said, hey, here's $20,000. I mean, it wasn't a lot, it was not what we needed, but because we already have a relationship with you, we're just going to throw some money at you because we know that you're dealing with COVID-19. And so I think that the relationship that funders build with the organizations that they partner with is really critical, and maintaining that trust and recognizing the work that they do, and knowing that your organizations that are community-based or are working on health, that they're going to be the ones that you want to look to for the next pandemic, because that's what they do. And MCN was really, I'm so proud of the work that we did, and we were able to respond because of our mission. And we did have enough, to sort of get us by. But boy, when we got some funding, we were able to do an incredible amount of work, and that made a difference and ultimately saved lives.
Julian, anything to add?
No, I mean, just reinforcing the building long-term partnerships. I think not responding to the fad of the day, but really looking at building partnership with specific organizations, and learning together, to Allison's point, and having this feedback loop, both between the funder and the organization, and then with the communities themselves. I mean, this is who we work for, and we need to hear from them. And I do think that the role of our organizations are also to be this conduit between the people that we serve and the initial funders, and having this dialogue continue. And again, built on trust, and trust needs time to be built.
Yeah, so I think those are all excellent messages, for us to kind of wrap up on. I mean, it is really trust, collaboration, really that long vision, that root causes, and looking at recovery, not just that immediate, Julian, as you called it, the fad. That's all the time we have for questions today. I really appreciate everyone. I want to provide the audience with some actionable thoughts from our conversation today. Disasters, be they a pandemic or some disaster from a natural hazard or otherwise, they need ongoing attention. Our slogan at CDP is all funders are disaster funders. And it's become better understood during the pandemic as funders began to realize that there was a connection between their focus issue and the broader implications of the pandemic. This remains true for the next pandemic. It remains true in the next disaster. Make sure your community is ready to cope with the shocks that come with a disaster. If you don't, it's really, we can't iterate that often enough. Support root causes. Disasters have a way of laying bare the inequities of society, which is true with COVID-19 and really rose up and got a lot of public attention during the pandemic. Everyone has been impacted by the rising costs of food, for example, but those who struggled with food access and nutrition before the pandemic are now in an extreme crisis. Funders need to look at those underlying issues and find ways to address them through funding and policy changes. And a number of policy changes were highlighted through this webinar today, and really, really good suggestions there. Follow the lessons of the pandemic. We saw a dramatic increase in funding during 2020, but it slowed in 2021 and 2022. Funders decreased their demands on grantees. They supported operating funds. They were flexible. They thought more about equity. They funded locally. They trusted more. These practices need to become our new normal. You can find many resources that can assist you in your strategy and in your planning on CDP's website. The issue insights provide an introductory look at disasters and responses. Disaster profiles provide regular information about a disaster's impact and a community's need to inform philanthropy and how they can help. The Disaster Philanthropy Playbook is now hosted on our main site and provides numerous resources for those planning disaster funding. There's a monthly newsletter full of information and blogs, including our weekly What We're Watching that highlights disasters around the world. CDP staff are always available to provide guidance if you need more in-depth assistance. We can also provide a variety of consulting services. You can find more information at our website, disasterphilanthropy.org. Our next webinar is in February. We'll be looking at the expanding hunger crisis around the world. We'll hear from experts from the United Nations and a CDP grantee working with trying to rush, and obviously that's never good to do when you're doing an acronym. LGBTQIA+ populations. Join us on February 9th at 2 p.m. Eastern for that discussion. In order to respect everyone's time and to keep this to an hour, unfortunately, that's all the time we have today for our webinar. Thank you to our co-sponsors, to Amy, to Alice, and for Julian for taking the time to share your insights with us today. Please take a moment to complete our post-webinar survey to let us know what you liked, where we can improve, and what we'd like to see in additional webinars. It will pop up automatically as you exit the webinar. If you have questions or thoughts not addressed during today's webinar, you may email them to Tanya at tanya.gulliver-garcia@disasterphilanthropy.org. The address is there. Thank you and have a great afternoon.